In this video, we're going to be talking about an uncomfortable but important topic in interventional radiology called feeding tubes. You or a loved one have been recommended a feeding tube, and that's a very scary thing, but I'm going to break down to you. Knowing exactly what to expect is not only the key to making right decisions, but it's important to make a speedy recovery and be happy with the procedure. So a feeding tube is a small plastic tube, usually made of silicone, that can be inserted directly into the gastrointestinal tract, usually in the stomach, but can also in some situations be inserted into the small bowel to provide nutrition and medications to patients that cannot swallow. So like I mentioned before, a feeding tube is most often used to provide nutrition and medications to patients that cannot swallow. Most often this happens after somebody had a stroke, but it can also happen in patients that have head and neck tumors that are gonna be undergoing radiation. And during the radiation, the entire swallowing apparatus gets inflamed and makes it very hard to swallow for a period of time. It's rare, but in some situations we also can put a feeding tube in patients that can't swallow, but they're having a really hard time taking enough calories to maintain their nutrition and getting enough energy to thrive. So the hope in these cases is that we put a feeding tube and provide enough nutrition so they can get stronger and be back to their normal health. Another situation that we would put a feeding tube in is for patients who are vomiting either because they have a bowel obstruction by cancer or even something benign, or they have something called gastroparesis, which is when your stomach cannot empty normally. We put the tube so we can vent the gastric contents or drain the gastric contents so the patient doesn't vomit. In these cases, we don't actually call a feeding tube, although it's the same thing, but we call them a venting gastrostomy tube. But it is placed and managed more or less the same way. What are the types of feeding tubes available and which one's the best for you? So there are several types of feeding tubes. The most simple and non-invasive one is called a nasogastric or a nasojejunal feeding tube. The difference between the two is the nasogastric is inserted through the nose and the tip of the tube is in the stomach. The nasojejunal feeding tube is also inserted through the nose, but we place the tip of the catheter into the small intestine, so the nutrition can be given in the small intestine. The good thing about those is they are non-invasive and they can even be placed at the bedside. However, they can only stay for a few weeks because they are uncomfortable and they could cause infections in the sinuses, for example, or could cause erosions in the nose or erosions in the digestive tract. And these are usually used while patients are in the hospital and they are either unconscious in the ICU or they are obtunded, and they are only used for a period of time. Now, if patients are going to require a feeding tube for a longer period of time, more than let's say 2 weeks, they will require something else. And the next step would be what's called a gastrostomy tube, which is a tube that is inserted through the skin directly into the stomach. And those are called gastrostomy tubes, or sometimes they are called PEG tubes. And I'll explain a little bit about that. There are also different types of gastrostomy tubes, which I will explain in detail. But for now, the important part is that they are tubes that are directly in the stomach. So patients can get their medications through the tube, or they can get infusion boluses, or essentially you can inject breakfast, lunch, and dinner through these tubes. In some cases, you can also infuse the nutrition slowly using an infusion pump over the period of 12 hours or even 24 hours. Now, this is the most common type of feeding tube because they're simple and they're easy to manage. And like I said, because patients can have breakfast, lunch, and dinner through these tubes, making the schedule easier. Now, some patients, when you infuse the nutrition in the stomach, they don't empty the stomach or they tend to vomit and then aspirate. In those cases, we would have to use a different type of feeding tube. And one of the options in those cases is what's called a gastrojejunostomy feeding tube. Now, this tube is also inserted in the stomach, pretty much like a gastrostomy tube, but instead of the tip of the tube be in the stomach, we then position using fluoroscopy or X-ray guidance through the pylorus, which is the exit point of the stomach, into the small intestine. So when you're injecting nutrition, although the tube is going through the stomach, you're actually injecting the nutrition directly into the small intestine. Now, the advantage of doing that is there is less chance of reflux into the esophagus and then vomiting, But the disadvantage is in the small intestine, you can't usually give breakfast, lunch, and dinner. You can't do what's called bolus feeds, which is injecting a large amount of nutrition there. You have to inject continuously and slowly over a period of 12 or 24 hours using a pump. And that makes things more complicated. These tubes are also longer, so longer tubes have a tendency to get blocked more often. So they require more care and being more diligent about cleaning the tube and making sure it doesn't get clogged. Some medications need to be injected into the stomach rather than in the small bowel, but these tubes usually have a part that is also located in the stomach. So you have the option either to inject in the small bowel or inject in the stomach. So usually what people do is they inject the nutrition in the small bowel, but the medications they put in the stomach. The stomach part is also shorter, so has less chance of getting clogged, and the medications is what gets the tubes clogged more often than not. So the gastrojejunostomy tubes are usually used for patients that have a gastrostomy tube and then they continue to have what's called aspiration pneumonias. And the theory is like you're injecting the feeding in the stomach, but it's refluxing through the esophagus and then the patient vomits and aspirates into the airway. Having said that, placing a gastrojejunostomy tube won't guarantee that the patient won't have pneumonias because they can continue to aspirate saliva and other things that can go into the airway and cause a pneumonia. So this topic is even somewhat controversial. Now, the gastrojejunostomy tubes are often useful for patients that have gastroparesis. Gastroparesis, like I mentioned before, is when your stomach doesn't empty well. So you accumulate a lot of fluid in the stomach. So basically, if you put nutrition in the stomach, it would just stay there. So in this case, you can put the nutrition to the jejunostomy part and that will go straight into the small bowel, but you can also use the gastric part to remove the gastric juices and the saliva that goes into the stomach so the patients can feel better and don't vomit as often. So how is the gastrostomy tube procedure performed? Now we're gonna talk about how do we place these tubes. So a gastrostomy tube can be done either by an interventional radiologist or by a gastroenterologist. Gastroenterologists usually place these tubes using endoscopy, and in these cases they are called PEGs or percutaneous endoscopic gastrostomy tubes. An interventional radiologist like me, on the other hand, use a different technique, and we place these tubes guided by imaging, either fluoroscopy or x-rays, or even in some cases a CT scan. And we tend to call them by their normal name, which is called a gastrostomy tube. And I'm gonna say in our practice these days, these tubes are placed and managed by interventional radiologists and rarely by gastroenterologists. So in this video, I'm gonna be focusing on how interventional radiologists place these tubes. And this is a pretty simple and straightforward procedure that should be taking 5 to 10 minutes. And it's a common procedure in our practice and we do several times a week. This procedure does not require general anesthesia and can be placed usually with moderate sedation or twilight sedation. That's when we give medications in the IV, so the patient doesn't remember the procedure and is comfortable throughout. And the way we can see the stomach in the x-rays and under CT is we place a small spaghetti-sized catheter through the nose or the mouth of the patient and guide them under x-rays into the stomach. Once that tube is in the stomach, we then inflate the stomach with air. And then the stomach is this big target that we can insert these tubes into. And once the stomach is inflated, we have two different ways of placing these tubes, and I'm gonna explain both of them. So the first way is actually my preferred way, which is called an inside-out gastrostomy tube. And the way this is done is the tube has a little mushroom on the back that will seal the stomach and prevent the tube from coming out. And what we do is we insert a wire through the skin into the stomach, and then we pull that wire through the mouth, and then this tube is pulled back in a retrograde fashion and comes from inside the stomach to the outside. And this is the whole procedure, and like I said, it usually takes 5 minutes. And this tube is very snug around the skin, so we get the best results in terms of healing around the tube. It has a less chance of bleeding and also has a less chance of leakage and doesn't require any anchors or anything like that, which I'm going to explain in detail. So in my experience, patients have way less pain when we do this type of gastrostomy tube, and they heal better. The second way that interventional radiologists can place a gastrostomy tube is what's called the percutaneous way. In this way, we have to insert like 3 or 4 needles in different positions in the stomach to insert these anchor sets to anchor the stomach wall to the abdominal wall, so to avoid leakage. Once the stomach is anchored, then we can insert another wire into the stomach, and we dilate the tract and put a hollow tube, which is called a pilloway sheath. And through this hollow tube, we can insert the gastrostomy tube. And these gastrostomy tubes have a balloon on the tip, and that's what maintains the tube in place. And once the tube is in, we remove the pilloway sheath. Now, there are a couple of problems with these types of tubes because you're putting 3 or 4 needles into the stomach. I think there's more risk of bleeding. I think these anchor sets can be painful sometimes. And also these tubes have a balloon, and sometimes the balloon can rupture and then these tubes come out accidentally. They are easier to pull out. I mean, don't get me wrong, these tubes have been doing for a long time and they work pretty well, but I think the inside out has some advantages. The exception is patients, for example, that have a tumor in the esophagus. So I don't want to be pulling a tube through the esophagus to come out in the stomach. So in those cases, I prefer to put the percutaneous one. It makes more sense in those cases. So what to expect after the procedure? So the inside out tubes usually can be used right away, while the percutaneous tubes usually can be used for medications right away, but we usually wait about 24 hours before we infuse nutrition through them. But most patients are fully awake after the procedure. They will recover for about an hour afterwards, and then they can go to do their normal activities. It's normal to have some pain in the procedure site, and usually Tylenol is enough, but in some cases, we usually prefer to avoid anti-inflammatories like ibuprofen and Aleve because they have a tendency to cause gastric ulcers, and the stomach's already a little irritated because the tube is in place, so it doesn't sound like a good idea. Patients can shower the same day with the procedure, and contrary to what some people say, I think it's okay to get the site wet as long as you dry after the shower. I actually prefer to keep the site clean than keep it covered and with the leakage and other things that may, I think, increase the risk of infection. What are the possible complications? So like I said, usually it's a safe procedure and we do a lot of them, but there is a risk of complications that in some cases can be serious. I would say the most common complication would be a risk of bleeding, and could be either bleeding around the tube, which is usually not a big deal, or bleeding inside the GI tract. That would manifest by either patients vomiting blood or patients passing blood through the stool. Usually when the blood comes out of the stool, it usually comes black because the blood gets digested through the GI tract. So it's called melena, and it's black stool, like coffee ground black. One of the things we monitor after this is when patients have bleeding, usually their blood counts drop, their hemoglobin drops, and that's one way we can know that there was a bleeding issue. Usually if the hemoglobin does not drop, even if you have a little bit of bleeding, it's not significant. If there is a bleeding complication, the next step would be to do an endoscopy and see where the bleeding is from. Sometimes we get tricked and we think it's bleeding from the procedure site and it's actually bleeding from an ulcer somewhere else. Another risk, which is the most dreadful risk, is the risk of leakage of gastric contents around the tube into the peritoneal cavity. This would only happen in the beginning, in the first few days, and it's really, really rare. But if it happens, it could be very serious and even require an emergency surgery. The way you would know is usually if that happened would be extremely painful and would not be painful just at the procedure site, but in the entire abdomen. So it's usually very easy to identify. The white count may also go up, and we're always watching for those things. Patients can also have an infection at the gastrostomy tube site called the cellulitis. And those are usually treated with antibiotics and they usually resolve. But the way you would know is you have the tube placed and usually you're doing okay for a couple of days and then the site starts getting red and painful. In those cases, you have to let us know and we'll treat with antibiotics right away and keep a close look. There is also a risk of injury to other organs during placement of the tube, especially the colon. Sometimes the colon could be in front of the stomach. Now, we usually check ahead of time and we look if you had a CT scan. We can also see the colon usually under x-rays. And it's very rare, but it's something that has been described. Nowadays, the imaging techniques are so good that it's really, really rare. Another issue is that sometimes this tube can be accidentally pulled out. And usually if they're pulled out after a few weeks, it's not a big deal. And most of the time we can actually reinsert them immediately through the same track without doing a major procedure. However, if the tube is pulled out in the first few days, that may be more challenging. It can be dangerous because you could leak gastric contents in the abdominal cavity. So it's important that if you pulled out the tube within the first couple of weeks, that you seek immediate medical attention for us to make sure you're okay, and also to find a way to replace the tube. It may be necessary to place a new tube altogether. But if the tube is pulled out after, let's say, a month, it's usually not an emergency, and you can come see us the next day, and usually we can replace the tube through the same track. How do you take care of the feeding tube? In medical terms, we call the area where the tube is placed in the skin, we call the stoma site. And essentially, the biggest message is you should keep it clean and dry. In my opinion, the worst thing you can do is keep it closed with dressings all the time and don't look at it, because the gauzes can get wet and that will irritate your skin and it will make more prone to getting infections at the site. I think if there's no significant leakage around the tube, you should just leave it open, and you can shower and clean during the shower as long as you dry immediately after that. Patients who have feeding tubes sometimes can even go to a private swimming pool or a hot tub if they have one. Of course, this after a period of a month or two. Again, it's very important to avoid moisture around the tube because that can lead to infections, skin irritation, and even fungal infections. Now, the tube itself, what do you have to do? So essentially, the instructions regarding the feedings and pumps or what nutrition you're going to use, they're going to be given by the dietitian. But the important thing from my perspective is after you give feedings or medications, you have to make sure you flush the tube very well to avoid that material to stay inside the tube, which long-term will block the tube and cause problems. I strongly recommend that patients have a consultation with a dietitian even before they get this feeding tubes placed, so they have a plan on how to use it and if they're going to be able to manage at home, and also what nutrition they're going to use in the tube. And like I mentioned before, there are different ways of giving the nutrition. You have bolus feeds where you give breakfast, lunch, and dinner and some hydration in between, or you can use a pump method where you use an infusion pump to deliver the nutrition over a period of 12 to 24 hours. Nutritionists can be very precise and they will calculate exactly how many calories and protein and macros do you need. Now, the important thing to know is if you have problems with the nutrition or how to do it, you should contact the dietitian. But if you have problems with the gastrostomy tube itself, if it breaks or if it's leaking or if you're suspecting you have an infection, the interventional radiologists like us, we are the point of contact, and we should contact our office or send us a message on My Health Online. So what about follow-up? So after we place the tube, we usually like to see the patients a few weeks or a month after the procedure to see how they're doing, if they're having problems with the tube, and to see how the stoma site looks like. At that time, we can also discuss another option, which is changing this tube to a low-profile gastrostomy tube, which is also called a button tube. So these are a lot more convenient because they are not heavy and they are just a button, and essentially people can have a normal life. They can even work out with those tubes, and in my opinion, they're a lot more convenient. So why wouldn't we put those in the first place to start with? To place those tubes, we need to know exactly the distance between the stomach and the skin. And they can be a little more dangerous if you place them as a first time. They don't seal the stomach very well. So we prefer to wait until the tract is healed to change for a low-profile gastrostomy tube. Again, if you're only going to need the gastrostomy tube for a month or two, then it's not worth changing. But patients who will need a gastrostomy tube long-term, a feeding tube long-term, I think it's a good idea to change to the low profile, especially if the patient is ambulating and continues to have a normal life. The way it's done is it can easily be changed in the office, and it's usually not a big deal. Some patients, over time, they actually learn how to change their tubes by themselves at home. The low-profile feeding tubes, they are like just flat through the skin. So when you're gonna use for feeding, you'll need to attach a separate tube into that button, and then you can infuse nutrition through that. But that's a very simple process. Does the gastrostomy tube needs to be changed? Yeah, most of the time these tubes are made of plastic and they will wear off with time. Also, some crud may accumulate inside the tube and they make more prone to clogging. So we usually recommend changing them every 6 months or so. Usually the pull-through feeding tubes, they will last about a year before they need to be changed. And sometimes you have problems at the hub that may crack, but those can be changed very simply by just removing the hub and putting a new one. We have a repair kit in the office. Now, what happens when you don't need the tube anymore? When we place these tubes, we have to usually wait at least 2 weeks, but probably better to wait a month before we remove them. But after a month, these tubes can be removed at any time. And it's a very simple thing to do. We essentially just remove them, and they tend to heal very fast in 1 to 2 days. You can have a little bit of leakage in the hole where the tube was for a day or two, but they really heal pretty fast. Now, very rarely if the tube has been there for, let's say, 10 years and it's completely healed around, it may happen that when you remove it, it may not close on its own. And in those cases, the patient would need either an endoscopy to put a clip inside the stomach to close that hole, or a surgery to close, but that's very rare. I would say less than 1%. Another issue that we sometimes see with these gastrostomy tubes is that patients develop a little growth around the tube site called a granuloma. That's usually the mucosa of the stomach trying to grow out. It's not a dangerous thing, but it can cause leakage and inflammation, can bleed sometimes. So in those cases, we tend to treat them. We use liquid nitrogen to freeze them, essentially like the same way that we freeze warts. And we can do this quickly in the office. So I hope this information was very helpful. I know if you or a loved one needs a feeding tube, it's very scary and there's a lot of information to be absorbed. But I think the key is knowing what to expect ahead of time will make things a lot easier. Remember, we are here to deal with any of the problems with the tubes that we place, but you also require a dietitian to handle all your nutrition needs, and that should be arranged ahead of time. As always, if you have any questions, feel free to reach out to our office.